So this is a nutshell of a snapshot of the histories that we have witnessed through our forefathers, the different innovative developments taking place or took place from the time from the prehistoric era. Say we can see here that the the blood sugar, the diabetes diagnosis is taking place through the sugar present in the urine, blood, and in of late through the interstitial fluid. So from 1500 BC, the Egyptians as well as the Indians first noted that there is polyuria, and the term modhumeho came into the picture. Then in 230 CE, Galen has noted that there is diarrhea urinosa, that means there is polyuria. And then 400 to 500 CE, Indian physicians found out that the onset at young age versus associated with overweight, that means the type 2 diabetes came into the picture. And with all this background, in 1921, the Banting and the Best first purified insulin, the regular insulin, and then subsequently we got NPH insulin in 1940. So from 1908 to 2018, we can see that initially the blood sugar was the sugar was checked through the urine, subsequently through blood, through different systems like through Benedict's reagent, then clean test, clinistics and all, then dextrosticks, dextrometer, then between 1980s to 2000s, the blood sugar checking by glucometer, the finger pricking blood sugar assembly, the self-monitoring of the blood sugar started taking place by glucometers. And then the era came with the interstitial fluid. The sugar is being checked from the interstitial fluid. That means in 2004, the first FDA-approved continuous glucose monitor from Medtronic came into existence. And subsequently, there was a tsunami of developments in terms of the CGM sensors, pumps, other innovations have taken place. So a century, almost a century of diabetes technology has been depicted in this picture. So when we are talking about these innovations in innovations in monitoring and management, so far as the management is concerned, then the insulins, the first and foremost, especially for the type 1 diabetes, what are the developments have taken place with the insulins? So the basal insulins, what are the basal insulins currently available? The intermediate acting NPH insulins, analog insulins, that means the basal insulins, that means the insulin glargine U100, then the second generation insulin, the glargine U300, and the degludec and on. Over a course of time, the different basal insulins, the first generations and subsequently the second generation basal insulins came into the picture. I'm not going into the details of the comparative analysis between the different insulins. So far as the ultra long acting basal insulins are concerned, these are called the second generation insulins, the glargine U300 and the degludec. So these are currently also available in our country. Now the question comes, we were happy with the NPH insulin or the first generation basal insulins. Now, why we needed the second generation basal insulin? There must be certain advantages which forms this second generation basal insulins the topmost priority in comparison when we compare it with the first generation insulin. So first of all, the second generation basal insulins, that is, they dosing flexibility. It can be given at either in the morning or in the evening. It doesn't relate it to the food. So this dosing flexibility is there. So far as glycemic variability reduction is concerned, the second generation basal insulins are way ahead. Then the blood sugar, the hypoglycemia, incidences of hypoglycemia. It is both the overall and the nocturnal confirmed hypoglycemia are quite
Dr. Acharya, you're not audible.
The apprehension which we always have, that is the weight gain. There is also very minimal weight gain with the second generation insulin in comparison to the first generation insulin. So because of these plus points, I think the second generation insulin is into the because there is some technical issue, that's why the slides are getting misrepresented. So and that's why there was a head-to-head comparable study, comparisons between the second generation basal insulins with the first generation, glargine 300 with glargine 100, both with the type 2 diabetes patients and with the type 1 diabetes patients. This is the famous EDITION study, so the EDITION trial. So the EDITION trials are different with the type 1 and type 2. EDITION trial in 100, the glycemic efficacy were more or less comparable in terms of the HbA1c reduction and the fasting blood sugar reduction when we did the meta-analysis of the addition studies. But the significance or the significant findings which came out while we did the comparison of the meta-analysis in terms of the safety profile, that means the hypoglycemia. So it has been seen that with the second generation basal insulin, glargine 300, there were 48% lower hypoglycemic episodes in comparison to the glargine 100, and that therefore this has secured a significantly improved important place in the diabetes management, especially with the insulins, both in type 1 and type 2 diabetes. Next comes the very recent one, the very recent development, that is the once weekly insulin icodec. In fact, that has not yet been rolled out. The phase 2 study has already been completed, and the phase 3 studies is going on. The phase 3 clinical trials are going on. So this is once weekly insulin icodec. The question is, who need this once weekly insulin icodec? Especially for those patients who are very worried about the needle prick, the needle phobia. And then the person who doesn't want to take too many insulins in a day. And I think for those patients, this is a boon for them, that once weekly insulin icodec. How this once weekly insulin icodec is different from the rest of the conventional insulins? Because this happens to be the first acylated insulin analog for once weekly administrations. What are the USPs of these insulins? It is tightly albumin bound. It is ultra low insulin receptor affinity and ultra long acting. The half-life is almost 196 hours in human. For once weekly administration in humans demonstrated in the phase 2 trials, and the phase 3 trials is underway. So far as the dosing schedule is concerned, the proposal for the dosing schedule is that it has to be given on a weekly basis. So the first week, second week, and third week. Now, those patients who were rather insulin naive, and those patients who were already on insulin, were already insulinized. So for insulin naive patients, so the first week, the dosing schedule is 70 units. And from the second week onwards, there will be 70 units as plus minus the titration, whichever is needed. I'm coming to the titration. And then third week, also the same rules to be followed. And for the previously insulinized patients, the criteria, the calculation is that is 10.5 into daily basal dose. Means daily basal dose, the patient which was taking already the daily basal insulins. So in the first week, 10.5 into daily basal dose, followed by 7 into daily basal dose, followed by 7 into daily basal dose, along plus minus the correction needed, titration needed. Now, how can we do the titrations? If the fasting blood sugar, the mean fasting blood sugar kept between 80 to 130, we have to continue with the same dose. If the mean fasting blood sugar less than 80, we have to reduce the insulin dose by 20 units per week. And if the fasting blood sugar is more than 130 milligrams per deciliter, we have to increase the weekly dose of this icodec by 20 units per week. So this is the dosing schedule has been proposed, though the phase 3 studies is still going on. And this is the Onwards clinical program with different once daily insulins along with the icodec. There's a different head-to-head trials, both with the insulin naive patients, type 2 diabetes patients, then with prior insulin type 2 diabetes patients, and with the Onward 6 dealt with the type 1 patients. What we could see from this different Onwards trial, that yes, for the type 2 diabetes patients, the baseline HbA1c was quite high, it almost always are more than 8%. And the HbA1c non-inferiority has been confirmed in almost all the trials. And in the type 2 diabetes patients who are not insulinized prior, the insulinized patients, for them, the HbA1c superiority is also confirmed. That means there is a statistically significant HbA1c reduction in the type 2 diabetes patients who are insulin naive, not that much in the type 2 diabetes patients who are previously insulinized, but the staggering incidences of hypoglycemia has been noted when it was used with the type 1 diabetes patients in Onward 6 programs. Next comes in our armamentarium is the fixed dose combination of GLP-1 RA, GLP-1 receptor agonist, and the basal insulin fixed dose combinations. Now, why this combination has been made? Because they have got a additive effects as well as complementary mechanisms of action. So we will be dealing with two agents which will have a complementary mechanisms of action, so that eventually will lead to better glycemic control in comparison to using the each and every agent differently or separately. Now, there are certain plus points with the basal insulins analogs, and there are certain plus points with the GLP-1 receptor agonist. So far as GLP-1 receptors antagonists, they are very simple to initiate. They basically control the postprandial blood sugar. Weight loss benefit is there, and the patients almost 40 to 60% of the patients achieve the target HbA1c control. And so for the basal insulin analogs, yes, for the nocturnal and the fasting blood sugar control, again simple to initiate. A bit of weight, very minimal weight gain is there, and relatively low hypoglycemia risk, and almost 50 to 60% patients achieve the target HbA1c control. So these fixed dose combinations is of very significance nowadays. These are the fixed dose combinations and the various GLP-1 RA based devices which are available, out of which few are already available in India. Like so far as the GLP-1 array and the basal insulin analog fixed dose combinations are there on the right hand side of the slide. We can see that there is Ideglira and the Idler Lixi, out of which Ideglira is already available in our country. And Idler Lixi is, I think it is Solico, it is already available in Europe and US. And I think in our country, it is not yet available. By this year end of next year, it will be available in our country. And so far as the different GLP-1 RS, we are well conversant with the GLP-1 RS, which are available in our country, like Victoza, Byta, Bydureon, the Trulicity. Ozempic is not available in our country. So, but the remaining we are used to.